Good morning.
Good morning. How are you?
I'm good. So we're doing a little intro today. This was a very impromptu podcast with Sophie Mengele, our new nurse practitioner, and Dr. Dennis Hughes. And we had Sophie in the studio, and then Dennis Hughes stopped by because he wanted to do an episode on bloating. So you went off.
I had other things to do.
You had other things to do. This is a really interesting episode. I learned so much, and I know you're applying some of it right now.
Yeah.
Yes, you're doing...
Doctor is the patient at the moment.
Yeah, what test are you doing?
I'm doing a breath test for abnormal bacteria in the bowel.
Right. And this is something that Dr. Hughes discusses on today's podcast. Lots of great information here on bloating. We hope you enjoy the episode.
Thanks.
Thanks. All right. Good morning, everybody.
Good morning.
So we have Dr. Dennis Hughes on the podcast today.
Hello.
Hello. And talking about a very exciting topic. Do you want to say what the topic is?
Yeah. On today's episode, we are going to be talking about bloating,
which is a great topic. Take it away.
First, I want to talk about what bloating is. Bloating is characterized by a sensation of trapped gas and sometimes even visible abdominal distension. In my practice, I ask people to send me text pictures of their belly before and after bloat. And
Wait,
one patient,
really?
Yeah.
Like side angle, front angle?
Both. The thing is that if
Before
I'm
and
not there to
after.
see it,
Yeah.
and it's not as concrete yet, I want to see it. I don't want just a description. And so I have one patient who had six-pack abs, so it showed me that. And after, you don't see the six-pack abs. But bloating isn't just about a feeling of trapped gas and distension. It can often be accompanied by abdominal cramps, constipation, diarrhea, or even alternating constipation and diarrhea.
Yeah.
Pretty
Wow.
common in the population and makes people
Very.
miserable, besides
Absolutely.
being socially embarrassing.
Yeah, I would say I hear people talk about bloating every single day at the office. Bloating comes up.
Yep.
Yeah.
Like, I don't feel like myself. Look at this.
Yeah,
I feel
can't
so
button
bloated.
my pants. Yeah, they don't like it. Yeah. So how would you start with someone like that? A patient?
I like the idea of the photos. I think that's
I do too.
such a good idea because a lot of times people come in, they're like, it's not happening right now, but I
Right.
swear it's there.
Yeah, if it weren't for the photos, I would have to go to a restaurant, sit down with them and have them order broccoli or something and just
Yeah.
see what happens. But-
And that might be a bit time consuming. So that's a great idea.
So the first job I have is to rule out something that poses an immediate threat to health or life. So the red flags, and those would be abdominal pain, not just cramping, but pain. Pain that may wake you up from a sound sleep. Also fever, weight loss that isn't otherwise explained by a change in diet, bloody bowel movements. And those are the symptoms and signs. And then there's the laboratory analysis. For example, if I see anemia or iron deficiency or abnormal liver test or other tests.
So is this anyone that's just coming in, or can you provide a bit more history on, is this someone who's having daily bloating? What kind of pattern is more suspicious?
So I think that for me, I'm going to do a laboratory workup at least on anybody with bloating, and I'm going to probably do a laboratory workup on them anyway.
Yep.
But as far as going further with it, it depends on how severe it feels to me. It's just the feel of it.
Yep.
And
Yeah.
for example, I might do imaging with an abdominal pelvic CT. And
During
maybe
the
even-
bloating? Or no?
Just in general.
Just in general. Okay.
Hopefully not during bloating, because that would be a very bad day. And how I progress with the workup depends on those initial discussion and workup. When I was a younger doctor in training, a lot of these symptoms, bloating, cramps, diarrhea, constipation, were associated with IBS. That was the diagnosis. But IBS, or functional dyspepsia, they're diagnoses of exclusion, which means that you have to rule out other things before you can confidently say, okay, I think it's IBS.
Yeah.
Now what I do, when somebody has persistent symptoms, I'm not just talking about the now and then. Maybe they overdid it with food one day at a party. That person I'm not going to be as concerned about, but somebody with persisting symptoms.
Yeah. There's a difference.
Yeah. Now my approach is that I do the workup right up front for everything that I can take actionable treatment for. Before I get into the differential diagnosis, I want to talk about digestion for a moment.
Yeah.
So when you eat, your stomach starts the digestive process by making pepsin, and your pancreas secretes enzymes to digest fat, carbohydrates, and protein. And on the surface of your small intestine, if you looked really closely up, it looks like a shag carpet from the 1970s. And this would look like long fingers called villi, and they're lined with digestive enzymes, and they also increase the surface area for absorbing water. So think about one of our favorite cities, San Francisco.
Yes.
It's only 7 miles wide, but it has a lot of hills. So if you were to take the ends of San Francisco and pull that flat, it would be much wider than 7 miles. Having those hills in San Francisco increases the area, the space, and your small intestine does the same thing.
That's a really cool analogy. I like
Yes.
that.
Some of the things that cause us to have digestive problems that lead to the bloating and cramps and so on affect those digestive enzymes and also the motility of the digestive tract. So I think patients often get frustrated and hop from doctor to doctor because they don't get the diagnosis, because 10 different things can cause the same symptoms.
And sometimes isn't it a lot of the time too, like when they're eating like the broccoli or salad, things like that you're more susceptible to bloating if it's food related?
In the right person, sure.
Yeah.
Or the wrong person. So they have to keep a diary. First, I'll talk about the causes of these symptoms that I can test for and treat directly.
Great.
One of them is called celiac disease, also known as gluten enteropathy. It is an allergic inflammation in the lining of your small intestine to gluten. And
can you talk a little bit about gluten sensitivity versus celiac disease for those that maybe don't know the difference?
That's a very good question. I'm going to get to that in a second, right after I cover this one. People may say, when I have foods containing gluten, I feel bloated, maybe crampy, maybe flatulence, because that allergic inflammation has affected the lining of the small intestine so that your ability to break down food with those enzymes is reduced. Your question, a lot of people think or assume that they have gluten enteropathy or celiac disease because they will eat certain foods and they'll bloat, and they assume this must be celiac disease. But maybe what they're experiencing is something called FODMAPs, which is an acronym for a mouthful. It's fermentable oligosaccharides, disaccharides, and polyols. And
what is that?
so basically, you don't have a sufficient amount of enzyme to break down fermentable sugars. So what's supposed to happen is when you eat these sugars, the digestive enzymes on the surface of your small intestine will break them down into small bits and pass them right through the gastrointestinal lining into the blood vessels, right into the bloodstream. So there should be very little left downstream for the bacteria in your colon to feast on. The bacteria in the colon are supposed to get the scraps, not the sugar.
Right.
And so if you don't break down those sugars and they pass downstream in the digestive tract, you're going to get a couple different things happening. First of all, those sugars are going to act like an osmotic agent, pulling in fluid, distending your intestines and making you feel full. Also, now you've given the bacteria in your colon a fermentable host of sugars, which they can break down and make gas from. So that's like a buffet for them.
I was going to say, that sounds like a bloating party, just waiting to happen.
This was studied, and in one study I read, people who had assumed they have celiac disease, when they adopted a special diet, avoiding FODMAPs, their symptoms got better. So what I tell people to do is, if you've noticed that certain foods cause bloating, minimize or avoid them. There's actually a do not eat this list that you can look up online, and you can look up FODMAPs diet. And it's pretty exclusive, it's pretty brutal,
I would want to do that.
What I ask people to do is in the initial part, we're just looking to diagnose.
Yeah.
So if I'm worried based on what you've told me that you might have a FODMAPs issue, I say, I know this is brutal, but just try this diet for 1 week.
Yeah.
If you've been having symptoms ongoing and suddenly they're dramatically better, there you go.
Yeah.
And so then you can add foods back from the do not eat this list. And if you tolerate them, you can circle that and say, okay, I tolerated that, I can eat that. This one I got bloated, I can't eat that.
Yeah.
Yeah. I usually try, maybe it's similar in your practice, but I usually pick the biggest culprits: gluten, lactose, those to try, cutting it out completely for a week, seeing how it goes. But could you talk a little bit about celiac and testing for that as well? Maybe you're getting to it.
Sure. I wanted to give one really good example in my practice that I had about FODMAPs. So I had a young guy. He watched a Netflix show on how animals are slaughtered for meat.
Okay.
And he was just immediately put off. He said, I'm going to be a vegetarian starting today. And a young guy, active, hungry, has to fill his belly with something.
Yeah.
So he starts shoveling tubs of hummus in his mouth. And hummus has FODMAPs.
Oh
And
my
here he
goodness.
is, bloating, passing gas, feeling crampy, uncomfortable. That's a perfect example. He tolerated hummus before, but when he started ramping up how much he ate, he overwhelmed his digestive capacity. And here come the symptoms. So
Could that happen with a lot of foods? Any food on the FODMAP list?
I think so.
Okay.
I
Just
think so.
eating too much of that one food.
Just overwhelming your digestive capacity.
Okay. So a sudden change in diet where you're cutting out one thing and you're supplementing it
more.
with more of something else.
Or maybe we're doing like a lot of us do, we're eating too fast. Supposedly, culturally, the French eat their meals slowly, they talk, they savor
sip
the dish.
wine.
They're just loving life.
They sip wine while they eat. We don't do that. We drink wine and
Chug a
then we
luck
eat.
and just scarfing down 3,000 calories in 15 minutes. Me and my brothers would fight for the food in the center of the table at dinner time.
Oh,
you know,
yeah.
just shoving it down.
I feel like here it's also not as community oriented. Like I feel
Yeah.
like in Europe,
That's a
people
good
sit
point.
down and you're sharing the food, you're talking about
an
the
event.
food. Yeah.
Yes.
And here it's like, all right, where can I go that's quick? I've got
It's
things to
family
do.
style. It's all set out in the center of the
Absolutely.
table.
Here
and
it's
you're-
like, no, this is mine.
Yeah.
And no one's touching it.
yeah.
And I'm just going to get it done and shove it in my mouth. I'm
Yeah.
going to get my coffee, drink it in the car as I drive down the street. I'm not actually going to enjoy my coffee. I'm just going to chug it in the car. But you asked a question about testing for celiac disease. So
Yeah. Because
the
that's
e-
something that's always a little bit backwards for patients. Like I can't see that you have these factors for celiac unless you're actually eating gluten.
So I do a blood test.
Yep.
That's the easy, non-invasive way to do it, and it's pretty accurate. The other way is to do a biopsy of your duodenum. So the first part of the small intestine that comes off your stomach, you can do easily with an upper endoscopy, but I wouldn't subject somebody to that unless there was another reason to do the upper endoscopy. For example, many times people with celiac disease malabsorb nutrients. You might find that this person is iron deficient. And not everybody with iron deficiency has a bleeding ulcer or a tumor. Sometimes they're just not ingesting enough. Maybe they're vegan, or maybe they're not absorbing it because they have celiac disease. So if somebody's iron deficient, we can kill two birds with one stone by ruling out scary things that threaten your health and your life, but also taking biopsies of the duodenum.
Yeah. I had a patient a few months ago who came in and he just looked white as a sheet. And I was
Like
like,
me.
oh my, not like you. No, but really, my other coworkers were like, did you get a hemoglobin on him? And it was, I think it was 4 or 5. And that's exactly what it turned out to be. Everything else
Wow,
looked normal.
interesting.
And yeah, it happened to be that he had celiac and had
Wow.
never known.
That should be, aside from gastrointestinal problems, that should be one of the things that's an obvious thing to test for, is the iron level, and,
Yep.
and for celiac disease to look for malabsorption.
Yeah. Can you talk a little bit about that? Is it the inflammation? Is it that parts of the duodenum that are supposed to be absorbing aren't? How does that happen?
Sure, it's the allergic inflammation in the lining, which renders the lining not only poor at digesting, but poor at absorption.
Yeah.
So
Yeah.
we take everything for granted when it works well, but the body's a complicated machine and a lot of parts can go wrong.
Absolutely.
Yeah, I had that test,
You did?
the endoscopy. I was glad that I know that I don't have celiac.
Yeah.
But
Sure.
Yeah. I mean, it's
Yeah.
as far as I know, the only definitive diagnosis. I do blood labs as well, but really to know for certain, you still need the endoscopy and the biopsy. Is that correct?
Again, when I see anemia, iron
Yeah.
deficiency, or other nutritional deficiencies even.
Yeah.
is that if you see someone that's really iron deficient, is that the first thing that kind of comes to mind? Celiac?
Is celiac the first thing? No, but I would include it in the differential
Yeah.
diagnosis.
Okay.
Obviously, I want to rule out the threatening stuff first. Celiac disease is unpleasant and it causes nutritional deficiencies, but it's not going to immediately threaten someone's health and life.
Yeah.
So there are a couple other things that I can test for that cause the same symptoms as celiac disease, and one of them is SIBO, small intestinal bacterial overgrowth. And it's becoming more and more common as a diagnosis, and maybe it's because more people are developing it, but maybe also because more people are looking into it as there is testing for it. The upper digestive tract, the small intestine, is supposed to have less bacteria than the colon, of course. Conditions that can cause stagnation of the gastrointestinal tract can cause bacteria to overgrow in the small intestine. And again, you see this issue of poor digestion and poor absorption. Someone who has had, for example, gastric bypass, or even if maybe they're on a GLP-1 agonist that slows the emptying of the digestive tract, you're getting stagnation. Or maybe you're taking a long-term proton pump inhibitor like omeprazole, which is Prilosec, and your stomach acid is lowered. So stomach acid kills bacteria in the food, but here you're having less stomach acid. So maybe some bacteria are slipping from the food through the stomach into the upper digestive tract. So now you've got an overgrowth of these bacteria that are producing 3 different types of gases: hydrogen, methane, and hydrogen sulfide. And again, those gases can cause distension, flatulence, cramping. Hydrogen and hydrogen sulfide can cause diarrhea, methane can cause constipation. And now we have, I believe, since 2001, a test which I can order for a patient and send it to their home. It's called Trio Smart.
Oh, wow.
What you get in the box is 75 grams of glucose,
Okay.
and you get 9 bags. And there's a valve, and you fill up the bag, you breathe out for 2 minutes and fill the bag. So you do a baseline.
Okay.
You drink the glucose 75 grams, and you start filling the bags with your exhalations every 15 minutes.
Okay.
And we're looking for heightened production of those gases, hydrogen sulfide and methane.
Huh.
And I got to tell you, when people have all these symptoms, it's not just about the uncomfortable and embarrassing symptoms that you're having, but people just feel lousy.
Yeah.
Maybe their energy is reduced. The good news is that if you diagnose somebody with SIBO, you can treat them with an antibiotic cocktail for that specific bacterial overgrowth. Now, it doesn't work in everybody, but if it does, it can be life-changing. And it does have a high recurrence rate. So you
Yeah,
can
that's
come
what I
back
was
in a
just going to
year.
say. Yeah.
You got to look at the risk factors, try and change them if you can. Maybe you can or not. I don't know. If they've had a certain surgery, like a Roux-en-Y gastric bypass, those are older. We don't do those as much anymore now that we've got Ozempic and Mounjaro. But if you can fix the risk factors, you do. And I've had a patient who was treated for SIBO, and about a year later it came back, or I assumed it was, and I treated it, went away again. So.
Nice. Oh,
No,
ahead.
go on. You go.
So when you have someone who's coming in with these really severe bloating symptoms and also constipation, diarrhea, are you doing all of these tests? Are you individualizing based on a little bit of their history? How do you figure out where you want to take the testing?
It's another great question. I used to do it individually.
Okay.
Let's do this one test. If that doesn't show anything, let's do another. I'm a little bit older now, as you can see. And I've learned that a lot of these patients are already frustrated with their symptoms for a long time.
Absolutely. Yeah.
And they've about had it. And so now I do everything up front.
Awesome.
And of course, I take a careful history about what you eat and what symptoms might follow what you eat. But yeah, I want to get it all done.
Okay.
So there's a third thing that I can test for. It's PEI, Pancreatic Exocrine Insufficiency.
Oh, yeah.
So this is a situation in which your pancreas is not secreting into the digestive tract a sufficient amount of enzymes to break down your food. And again, the common theme is that you're not digesting your food and the symptoms come. So some possible causes are surgery to remove some of your pancreas, injury to the pancreas, chronic pancreatitis, which is not uncommon in heavy drinkers. But there's autoimmune pancreatitis, which is less common, but it happens. I've got a patient with that. And they get all the same symptoms. And there's a stool test called fecal elastase. It's an enzyme, and you're looking for a value above 100 to be normal. And I have a patient who was recently treated for that. Symptoms are gone.
Wow.
Wrote a letter, can't believe I put up with this for so long.
Oh.
He said he feels better in general, energy, sense of well-being, not just
Wow.
abdominal symptoms. So
How did you treat him?
enzyme supplement. It's called ZenPep, and it is a cocktail of pancreatic enzyme supplements making up for what you're not producing yourself.
Oh, wow.
Amazing.
I will say about 25% of people with PEI don't have an obvious identifiable cause of not producing enough pancreatic enzyme. So you just have to do the test and act accordingly if it's abnormal.
Yeah.
So then if I don't find anything from that initial workup, I'm going to focus on, do you have functional dyspepsia or IBS? I'm going to ask, do you correlate emotional symptoms with digestive symptoms? I always think back to like when you're young and you're on a date and you're just nervous and you're attracted to that person, you got butterflies in your stomach, maybe you got to run to the bathroom. If someone tells me a story like that, when I'm put in a stressful situation that my symptoms are ramped up, especially if they don't have any red flags in their history, in their workup, I'm going to assume maybe they have IBS.
Because IBS is more tied to an emotional component.
It doesn't
Or
have to be,
stress,
but it
or-
can be. It often is, yeah. The stress will heighten the symptom frequency and severity, which is going to vary from person to person. But there's also something called the migrating motor complex. So I had read that there's migrating motor complex 3 is not functioning properly, and you may get abnormal peristalsis. So peristalsis, for those that are listening, is the waves of contraction of your digestive tract that propels your food and waste forward from A to Z. And that is just not functioning properly. But there is a brain-gut connection. The wires are connected.
So what are you saying when you say that?
I mean that whatever is going on in your brain, if your brain's on DEFCON 1, you're stressed, you're depressed, it may affect the functioning of your gut.
Of your gut. That's why people let it go for so long, I think.
They just figure
It's normal. Yeah.
They
Connected?
think, yeah, I think they're creating it.
Yeah.
Like it's their own fault.
it could be. That's what it is. But of course, like I said, we need to do the workup and rule
No,
out
I think
anything.
that's why this is a good podcast.
Yeah.
Yeah.
I have a question. So you talked a little bit about the overgrowth of bacteria and how there could be a component of a GLP-1 causing that, having that slowdown. Do you think there's any
I'm
risk?
speculating.
He's speculating. Okay.
I'm just saying that in general, stagnation.
Yeah. Do you feel like that maybe in your speculation, do you feel like this is something we might see more of for all of these people who were putting on higher doses of GLP-1s?
Sure, but you have to look for it. You have
Yeah.
to do the test. Thanks for asking back about that. I will say that the Trio Smart test, which is probably the best test, is not terribly expensive. Insurance should cover it.
Okay.
Medicare covers it completely. Commercial insurance may cover part of it.
Wait, which test was that again? The blow in the bag one?
Yes, the
Okay.
blow in the bag test, the Trio Smart,
Okay.
Trio because we're looking for 3 gases.
Okay.
And the cash price, I think, is $349.
So you get them who orders the kit?
I do.
You order
so
a kit?
the practitioner has to get an account number.
Okay.
That's easy. You just go on the Trio Smart website.
Okay.
I talk to
Sophie.
the rep, and I talk to the rep, and I get
Writing
an account
down
number.
notes.
Yeah.
I can go online and I can order it. They ship it to the patient. They bill the patient. Or in case
Right.
of Medicare,
Amazing.
maybe they don't get a bill. But to go one step further, I always want to try and find one problem that explains a person's symptoms, but that's not always the case.
Mm-hmm.
Some people have two or more different causes of the same symptoms. For example, in the patient that I told you, he has PEI, pancreatic exocrine insufficiency. He also has SIBO. So,
wow.
Okay, so you can have more than one of these things happening at the same time. Okay,
yeah, again, that speaks to why I do all the tests up front now. Because
absolutely.
I think as I've gotten a little more experienced over time, I've realized that if I see something and I treat it, maybe I miss the other thing by saying to myself, oh, I found that reason. I don't need to look elsewhere. I think that's a mistake now. And again, I always try and rule out the scary stuff first, but now try and look for all the causes of abdominal misery.
Yeah. So something that I've seen a lot in my practice, and I'm wondering if you have as well, is H. pylori. Can you talk a little bit about that and whether this is different than the symptoms that you're seeing in these patients?
That's a trickier answer because I'm sure, as you found, that H. pylori can cause no symptoms or maybe it's just that you've done a routine physical, and I do iron studies in everybody as a routine for screening. I don't wait to see anemia first. So sometimes I'll look for H. pylori if I see anemia, but
Should we explain what H. pylori is for people listening?
H. pylori now has had a change in name, but we're still calling it H. pylori.
What's the name change?
So it's Helicobacter pylori in the past, now Campylobacter pylori. Of course, we need to change the name every so many years for a reason I don't understand. But
to update the textbook, so you need to buy the newest
so we
version.
can put out a new edition of a textbook. But I'll still call it H. pylori. It's a bacterium that can reside in the stomach and cause a chronic inflammatory reaction in the lining of the stomach, which is called gastritis. And gastritis can occur with or without an ulcer. Now, when we started doing more upper endoscopies, we realized that lots of people had completely symptom-free ulcers, especially if they were a more shallow ulcer. And it's a bad thing to miss Helicobacter pylori because not only can it cause bleeding and anemia, it's a carcinogen. The chronic inflammatory response against H. pylori can cause adenocarcinoma of the stomach. And the good news is that if you identify this and you treat it, that risk of adenocarcinoma goes away. And
How do you treat it?
you treat it with a cocktail of a proton pump inhibitor, like omeprazole, Prilosec, and multiple antibiotics at the same time over 2 weeks. And then you have to retest for H. pylori to make sure you've eradicated it. So there are two ways to do that, as I'm sure. You can do another endoscopy, which most people are probably going to do because if that person has gastritis and or an ulcer, you want to make sure that's healed up in time. But there's another test you can do as well. You can do an H. pylori stool antigen test. It's another stool test. It's highly accurate, and you're looking for a molecule in the stool. And if it's not there, you can assume that H. pylori is gone. I've seen adenocarcinoma in one of my patients. It was really ugly. Hers was incurable, but she had to have a surgery anyway because that adenocarcinoma was near the gastric outlet as the stomach empties into the small intestine, the duodenum. And to have that obstruction is so uncomfortable and unpleasant. It causes pain and vomiting. So despite the fact that her condition was likely incurable, she still had a surgery to relieve that obstruction for that time. But the good news is it's easily tested for.
Yeah.
It is. Yeah, I was going to say, I don't know if you routinely use this, but we also use breath tests, which is why it came to mind when you were talking about the home test. Not that we offer it for at home, but a lot of times patients choose to do a urea breath study. Yeah. H. pylori, it's transferred through food, water, and I don't know if it's this particular region, but I have a lot of patients who come in with this epigastric pain, bloating, feeling super inflamed and distended, and I've just started adding that to my panel as well.
I think it's a great idea in general for health because there could be many people that come to see you who are harboring H. pylori and would not know it. Maybe they don't have any symptoms at all.
And you can't get over it on your own immune system, can't clear it.
I wouldn't take the risk,
No.
especially given that it's a carcinogen.
Yeah.
Yeah. But like you said, it's treated quickly, 2 weeks. And I usually do 3 different antibiotics, 1 medication to help line the stomach, and you retest for it 6-8 weeks after and hope that it's gone. And if not, retreat.
Yeah. That's a good idea. I think as being in women's health, we have patients calling always, and I know, Dennis, you have a story about ovarian cancer and bloating. That's their number one worry when they have this distended lower.
Yeah, that's one of those things, part of the red flag list that I look out for. So thank you for bringing that up. I had a middle-aged patient come to me, and she was really petite. She said, my pelvis is swollen. Can't button my nice jeans anymore. And she'd been told, oh, you're gaining weight. You need to diet. And she says, diet? I'm skinny. Look at me. And I get it that with menopause, we redistribute fat to the center of us, the viscera, the fat that surrounds and encases your organs. But in a middle-aged or older woman, you have to rule out ovarian cancer. And that's an easy test. It's a transvaginal ultrasound. And this patient did have ovarian cancer. And last I spoke to her years back, she was cured.
That's
Amazing.
great.
You have to look out for it. You just can't assume these things are.
No, you can't. And
some
an ultrasound,
innocuous.
it's low risk. We offer it at TMA.
Yeah.
Yeah. And it's so worth doing.
I think that's most of the list. I would add one more thing.
Yeah.
It's just constipation.
Yeah.
This is constipation without any other real pathology. Your digestive tract is propelling air and food and fluid and waste products from A to Z, mouth to anus. And as we age, a lot of us have slow colon motility. So the colon is just emptying slowly. And many of those patients are on certain medications which can slow the digestive tract from emptying. Think of your colon as a waste disposal and also water reclamation. So your colon has to dispose of the waste, but also to draw the water back into the body because your body's efficient and it doesn't really want to dispose of water, it wants to hold on to it. And so if your colon empties more slowly, it has more time to draw the water back into the system. And so if you're an older person with slow colon transit time, as we call it, you're going to empty your colon slowly, you're going to have stool, and you might just be gassy and bloated because of that. And that can easily be seen on imaging. Even in X-ray, we can see stool in the colon. And it's a quick and easy test to do if somebody's got chronic bloating. And they'll usually tell you, my stool is hard. I only go to the bathroom to have a bowel movement 2 or 3 times a week. Just by their history, you'll know that they're not emptying fast enough and you need to speed that process up a little bit.
And how do you do that?
There's simple and then there's less simple. I try and start simple with soluble fiber supplements that feeds our healthy microbiome. And that's the community of hopefully healthy bacteria that we have residing in our colon that has learned to live with us and has a lot of health benefits.
What's a product you like?
Metamucil's fine.
Okay.
Yeah.
Over the counter. Yeah.
Unfortunately, sometimes that can cause bloating as well, but
It
you have
can,
to try it
yeah.
and see. But
I always say they sell psyllium husk at
it-
Trader Joe's.
give it a go. And then there's other things like Miralax, which is polyethylene glycol, which reverses the flow of water from the inside of your colon, where it usually gets drawn into your vessels, back into the colon. So you're drawing fluid back into the colon, and that makes the stool softer and propels the stool out of you. And sometimes I might add to the fiber, I might add docusate, also known as cholate. That's super gentle. It just softens the stool without causing diarrhea. There's a stimulant laxative called Senecot, I use that sometimes, but I try not to overuse it because I'm afraid of making the colon dependent on
Yeah,
that.
that's the problem with all those things.
Yeah.
I think.
You don't want to treat one problem and cause another.
Yeah.
And if none of that works, then I get into prescription medications. The problem with those is that for a lot of people, they're just too strong.
Yep.
And they cause cramps and diarrhea.
Yeah.
So I get
Got to stay
phone
in the
calls.
sweet spot.
Yeah. So there is an older medication called Amitiza, and it's one of the first prescription medications for constipation. Sometimes older medications are just as good, and this is a gentle one. And I tend to use like a pediatric dose to start. It's supposed to be dosed twice a day, but I start once a day. I don't want to overdo it. I figure starting slow is always the way to go. You can always move up if you need to. And also, I'll close out by saying older people lose their thirst mechanism and they forget to drink water, and that can be a cause of constipation. What happens is when you start to dry out, when you get dehydrated, your blood sodium concentration goes up. There's a place in your brain, the hypothalamus, that detects that, and it secretes something to make you thirsty. And it gives you that signal, go to the fridge, get something, drink. Older people can be dry and not feel thirsty. So for those people, and they'll admit, I don't drink enough water, I'll tell them to do scheduled fluid drinking.
That's
So
a good idea.
I drink something, I don't know if you know what Spindrift is.
Yes,
It's
I've
low
got
calorie,
got one in my bag.
mild fizzy, I love it. And it's tasty. And it's very low calories. And I'll tell them to do scheduled drinking. So I have one when I wake up. I have one probably a couple hours later.
What is Spindrift? Sorry, show me in your bag.
Very lightly
It's in my bag.
carbonated.
It's either in my
Oh,
bag.
it's lightly carbonated.
Lightly carbonated, so it's
Okay.
not going to bloat
Oh,
you
it's
up.
in a can?
It's in a
Yeah.
can,
Oh,
but
I've
they're
seen it.
great because
Okay.
it's just a little bit of fruit juice. So
But it's
it tastes really
carbonated.
natural. Yeah, it's
But is that
carbonated.
good
light,
for-
though. It's
for
not
like-
like Topo Chico or
Okay.
a Perrier.
They're soft bubbles.
Okay.
That's a good way to put it.
Okay.
But I tell them to have one in the morning when they get up, have one a couple hours later, or maybe at lunch, have one in the late afternoon, have one in the early afternoon, early evening. And older people probably shouldn't have too much fluid close to bedtime because they're going to
They'll be
probably
up.
wake up.
Yeah.
A lot of older people don't understand why this happens. I don't want to get too off topic, but just to touch on this, is that there's something called anti-diuretic hormone that helps us keep our fluid in the body. So if you're at the Grand Canyon hiking and it's hot and you get dehydrated, your body's going to make anti-diuretic hormone to hold the fluid in your body to keep you hydrated and to prevent you from making urine because your body wants you to hoard that fluid. As we age, that peak of anti-diuretic hormone that we get at 7 to 8 at night when we're younger, and that holds our fluid in our body so we don't make much urine during sleep. That's why we can sleep through the night when we're younger. That fails us. It drops a bit with age. So that if you drink too much fluid close to bedtime, you're probably going to wake up to dump that fluid. But yeah, 1 can or glass in the morning, late morning or lunch, a couple more times, but not too close to bedtime.
Okay.
Hey.
I feel like I learned a lot. So to sum it up, bloating could be many different things. You want to rule out the red flag stuff first and then go from there. Just test everything and see
And
because
treat,
it could be,
and treat it.
yeah, more
Don't
than
Don't
one
live
thing.
with it. Don't live with it.
Yeah,
right?
you don't have to live with it. Treating your bloating, your gas, your cramps, your constipation, your diarrhea can be life-changing.
Absolutely.
So it's worth the effort to come to your practitioner and do the full workup.
Great. Thank you, doctor.
Thanks for having me.
Thank you, Nurse Sophie. All right.